years. During this period, there are a few characteristics as a high thoracic compliance, a low lung compliance with a low functional resident capacity with a high strength diaphragmatic. We are on high distal resistance and there are immature central control. For this reason, we have a high and variable respiratory rate, O2 consumption, and a low tidal volume. There are some specific reflex with a very strong herring barrier. For all these reasons, the respiratory fatigue and atelectasis could appear very quickly. So we just have seen the feature of immature lung. We need to know preoperative condition is in critical time too because of pulmonary arterial hypertension, bronchial hypersensitivity due to left to right shunt. The extracorporeal circulation is an additional insult with a high extravascular pulmonary water, a decrease of lung compliance, an alteration of the surfactant, and if many transfusions are required, a risk to develop a TRALI. For all these reasons, this lung have a high risk to develop a VILI. So the ventilation is very challenging for this patient, and there are some specific points. Some patients have a high risk to have a long-term ventilation. Some patients could have a phrenic nerve damage after the cardiac surgery. It's very important to understand and to take care of the heart-lung interaction, specifically the right ventricle dysfunction. And for some specific surgery as a Fontan, we need to have a specific care. Fontan is an intervention where the right ventricle doesn't work and all the systemic blood flow return through a tube like this. So we understand very well a very high positive pressure can compromise the passive flow. So we need to respect for this patient the spontaneous ventilation. So let's move to the next point, NAVA as a ventilatory tool for this specific patient. We know NAVA allows protective ventilation. This is a study of Colombo. They showed a physiologic response to varying level of pressure support and NAVA in adult patients after an acute respiratory failure. They demonstrated for a high level of support, pressure support ventilation have a high tidal volume per kilo. And we know a high pulmonary volume is associated with a high vascular resistance. So for our specific patient with the right ventricle dysfunction is very frequent, NAVA seems very helpful for this situation. So the second point is the interest of NAVA to practice a diaphragmatic training. Let's go back to this famous study where they compared 14 brain-dead damaged organ donors before organ harvest. They were ventilated during 20 to 70 hours with a diaphragmatic inactivity. They compare this patient with 8 patients they had an intraoperative biopsy specimen, and this patient was ventilated during 3 hours with a total diaphragm inactivity. And they showed a very rapid atrophy of diaphragm myofibers. So, for our patients, we know some patients have a high risk to develop to have a long-term ventilation because it's a neonatal population with bronchial pulmonary dysplasia, because they have a major surgery with a delayed sternal closure, peritoneal dialysis, of if require hypothermia during the surgery. And some patients could develop ICU-acquired paresis because of the use of corticosteroid or due to undernutrition. So this patient could develop very quickly a diaphragm atrophy. So we understand a training with NAVA could be very helpful. And another interesting point is the possibility to make a rapid transition in NAVA NIV. This is an study by Camarota. They showed the benefits of NAVA versus pressure support during NIV with an helmet, specifically for the index asynchrony less than 10% with NAVA compared with pressure support. We can see the very important number of ineffective asynchrony in pressure support ventilation. So for our patient with a very difficult time for the weaning, for the heart, it seems very interesting to conserve the synchrony patient ventilator during this critical time. Now let's move to the next point, NAVA as a monitoring tool. We have very often patients with a delayed sternal closure, and this patient requires a heavy sedation. But it's possible to monitor this sedation with a NAVA probe, and if to adjust the level of sedation. And if it's possible, if we have the good level of sedation for this patient, for example, with a delayed sternal closure, it was possible to have a nice diaphragm activity and to ventilate this patient in NAVA. It's very important to have a shorter period of weaning. So another interest is the monitoring for phrenic nerve damage. In cardiac surgery, it's not very common, but sometimes happens to have a unilateral paralysis, for example, this patient with a pacemaker. And the recording of the ADI for the unilateral paralysis show us a nice waveform, and sometimes we noted a higher level of EADI. Of course, for bilateral paralysis, it's very interesting to make the diagnosis with a flatline signal of the ADI. And another point is very useful to estimate the diaphragmatic recovery, especially for the patient with a long-term ventilation. This is an example we have reported with the PQ Montreal team. It was a 5-month patient with a botulism. She was ventilated in the unit, and this in the screenshot of the first day when she arrived in the unit, and we can see the flat line of the EADI. It was very interesting to see days after a nice waveform, a recovery of the diaphragm activity. For this patient, the association of the spontaneous breathing trial and the monitoring of the EADI was helpful to determine the appropriate moment to extubate the patient. And on this chart, we can see the progressive recovery of activity of the diaphragm. And the last point is NAVA as a monitoring tool to estimate the extubation tolerance. This is a Chinese study. They enrolled 21 children after an open-heart surgery, and they compare EADL signal for patients needing reintubation or NIV and patients with unsuccessful extubation. The point is not the absolute value, but the kinetic of the signal before the extubation and few hours later. Now, let's move to Necker experience. I would like to show you this patient. We have lots of patients with a delayed sternal closure, and we know we need to have a heavy sedation for this patient. And very often we use HFO ventilation to ensure a protective ventilation, but it's still possible to use a EADI monitoring to adapt the level of sedation. And the point is, at the closure of the sternal, it's possible to switch very quickly to NAVA. Currently, there are studies in the unit which compare the duration of ventilation of patients with HFO ventilation straight away to NAVA versus HFO ventilation, pressure control, and pressure support. And the last slide is to show you an example of patient with ECMO and NAVA. It's a 22 years old patient with complex cardiopathy. He needs 2 Blalox and 1 modified Fontan, as this patient was very sick with arrhythmia, chronic renal failure, aortopulmonary collateral, and he was very cyanosis. So she needed to take down the Fontan and put a fenestrated extracardiac tunnel. It was a very long surgery. So the evolution was very complicated with an IRDS required HFO ventilation. And a few days after, because of very severe arrhythmia, he needed a femoral arteriovenous ECMO. The patient the day after was ventilated with NAVA to preserve diaphragm activity, and few days after he was extubated with success. And 7 days after he was weaned from the ECMO. And now the patient is doing well. So in conclusion, we have already know NAVA improves patient ventilator synchrony and respect respiratory variability. For our very specific patients, NAVA seems very helpful as a ventilatory tool to ensure protective ventilation, to prevent VLI, to improve heart-lung interaction, to practice a diaphragmatic training for a patient with a long-term ventilation, and to make a relay in NIV. It seems very interesting as a monitoring tool to adjust the level of sedation, to estimate the diaphragmatic recovery, to determine the appropriate moment to extubate the patient, and to follow this extubation tolerance. Of course, we need to have some specific pediatric study on on the efficacy on heart-lung interaction and duration of ventilation. And I'm so sorry for my so terrible French accent.